The next presentation will be from Professor John Cleland. He's Professor of Cardiology and Director of the Robertson Center of Biostatistics, Glasgow, University of Glasgow, Scotland. Actually, the presentation is about a very important subject regarding the definition of heart failure. Now everybody is managing heart failure, the cardiologist, diabetologist, endocrinologist. So I think we need a universal definition of heart failure. Dr. Cleland, welcome, and please, the mic with you.
Yeah, that's maybe better. So we're having a bit of technical problems here. Need to go back to the beginning. No. There we go. So good morning to everybody in Egypt. What's happening? Good morning. I hope you can hear me.
Yes, we can hear you well, Dr. Cleland. Go ahead, please.
Thank you very much. So that was a brilliant talk from Professor Mullins, and I think my talk fits in very well with that, but perhaps before the onset of congestion, what can we do before that becomes clinically obvious? So what I want to talk about is why we need a universal definition of heart failure. It sounds like we have a very sophisticated audience of cardiologists, and of course they will be aware that heart failure is the final common pathway of many cardiovascular diseases. Not just the HFrEF and HFmREF and HFpEF that we know and love from the guidelines, but also valve disease, atrial fibrillation. It can be vascular disorders. We have many different reasons for cardiac dysfunction leading to heart failure, many etiologies. But we do have a common aspect to cardiac dysfunction and heart failure, and that is dilatation of the left atrium. And we pay an awful lot of attention to the left ventricle, but we don't pay nearly enough attention to the left atrium. And it doesn't really matter which phenotype of heart failure you have. If the cause of heart failure is left ventricular disease, the left atrium will be dilated. So when looking at the echocardiogram, having taken a quick look at the left ventricle, the next thing that you should do is look at the left atrium. So we have some problems when it comes to the definition and diagnosis of heart failure. First one I'd like to point out, and we've done this with numerous cardiovascular diseases, that basically you don't die unless you develop heart failure. There are an unlucky few who will present with sudden cardiac death as the first presentation of cardiovascular disease, but that's relatively uncommon. And of course, if you present with sudden death, there's not a lot of other things that we can do for you. But if you have a myocardial infarction, if you've got valve disease, if you've got an arrhythmia, if you don't develop heart failure, you're unlucky if you die. Most people, unfortunately, develop heart failure. So detecting heart failure early and managing it, I think, is very important if we're to alter the prognosis of cardiovascular disease. Of course, many people do have cardiac dysfunction but don't have heart failure. And you can see even people with an ejection fraction of less than 35%, if they have a normal, if they don't have congestion, they actually have quite a good prognosis. In fact, an excellent prognosis. They're unlikely to die of heart failure despite that very low ejection fraction. And likewise with valve disease, if you've got valve disease but you don't have evidence of congestion, it's unlikely that you're going to die from your valve disease. and we have little evidence of benefit from treatments that are effective for heart failure, that they benefit these people who have cardiac dysfunction but not heart failure. So that's important. But probably the third bullet point on this slide is the most important, that in 50% of cases, the diagnosis of heart failure is only made once symptoms and signs are so severe that the patient is hospitalized. This idea that patients come to their primary care physician and the primary care physician makes a diagnosis of heart failure when they're just breathless after climbing 3 flights of stairs and so on, that really just doesn't happen. The majority of cases of heart failure, the patient is sick enough that they need to be hospitalized. And if you're hospitalized with a new diagnosis of heart failure, you've got about a 50% chance of being dead within 1 year. All of these studies that you see that we produce and publish with SGLT2 inhibitors and ARNIs, etc., remember, those are studies amongst the survivors. The people with the new onset heart failure rarely make it into clinical trials. There's very few clinical trials of new onset heart failure. This isn't just new onset heart failure, this is just any old heart failure, but I guess about a quarter to a third of these patients are new onset heart failure. This is the national audit for England and Wales. There's now about 500,000 patients in this audit. And you can see that the prognosis, despite the fact that most of these patients are discharged on guideline recommended therapy, which has improved dramatically since the introduction of the audit, most of these patients, of course, are in the 65 to 85 year age group. You'll see that the 3-year mortality is still round about 50%. It doesn't really matter whether you have a reduced ejection fraction or not. Although notice that, different to some other countries, the majority of the patients admitted with heart failure in the UK are still HFrEF rather than the HFnEF. So this is a figure, an old figure that when I was in the 2001 guideline group, where we attempted to define what heart failure was. And we made the distinction between cardiac dysfunction and heart failure, and we used symptoms as the guiding principle to make the distinction between cardiac dysfunction and heart failure. If you could abolish symptoms and withdraw symptomatic therapy, then the patient had the possibility of condition we might call transient heart failure, moving back to cardiac dysfunction. If they have dysfunction with symptoms, then heart failure. But of course, this is a problem. As I pointed out, that symptoms are a late feature of cardiac dysfunction and congestion, and perhaps we need to go somewhere else with this. Well, we could think of it in terms of heart failure as a condition with a poor prognosis and has a high morbidity and mortality. That doesn't really help us define heart failure, really. It's part of the syndrome. It's a late in terms of giving any diagnostic information. In fact, it's retrospective. So it's not going to help us confirm the diagnosis. These patients, it's far too late. We could think about symptoms and signs. The problem is that the sort of earlier symptom of heart failure is breathlessness on exertion. But the problem is that everyone gets breathless if they exert themselves enough. And there are many causes of exertional breathlessness. You can be unfit, you can be fat, you can have lung disease, joint disease. And of course, many people attribute getting breathless as they get older to old age itself. We have the other problem, of course, that avoiding exercise prevents you getting breathless. So we find more and more patients, as they develop heart failure, they take less exercise, they watch more television, they sit on the couch more, and they don't then present to medical for medical support until they're breathless at rest. Of course, if you're breathless at rest with orthopnea, this indicates quite late severe disease and will often lead to hospitalization. Peripheral edema is the other classic sign of heart failure. It has a poor specificity and also may be a late piece of evidence that the patient has heart failure, often due to right-sided cardiac dysfunction, as mentioned in the previous talk. So what about looking at cardiac dysfunction? We have two approaches to that. We have imaging, for which you need specialized equipment and staff. There is a problem with measurement imprecision. We have a lot of inter-observer variability, and many echocardiograms, the evaluation is incomplete. They'll tell you about the valves, they'll tell you about the ventricle, but they completely forget to tell you about the atrium and the inferior vena cava. Cardiac dysfunction, yes, it might be able to tell you whether you've got cardiac dysfunction, yes or no, in terms of, and it might also tell you about the cause, whether you have left ventricular dysfunction or valve disease. It can tell you a lot about whether you have congestion from the atrial volume, but people really don't, I think, pay enough attention to that. And then the other way that we can think of assessing cardiac dysfunction is with biomarkers, either to use NT-proBNP or BNP. It's a standard blood test. A primary care physician, a family doctor can do this test. If it's normal, you know that the patient doesn't have any serious cardiac or renal disease. If it's raised, it indicates congestion. It doesn't tell you why the patient's congested. It could be that you have cardiac dysfunction, and that could be valve disease. It could be ventricular disease. It can be HEF-NEF, HEF-REF. It could be atrial fibrillation. And it also doesn't clearly distinguish between cardiac and renal dysfunction. But of course, you should measure the serum creatinine when you measure the NT-proBNP. And that will tell you where the patient lies on the spectrum of cardiac and renal dysfunction. Because remember, heart failure is a cardiorenal problem. It's not just a cardiac problem, as Professor Mullins has indicated. If your kidneys don't retain water and salt, then you won't go into heart failure. You might go into shock, but you won't go into what we know as chronic heart failure. So we need an early diagnosis, and we need an early diagnosis of cardiac disease, and we need an early diagnosis of congestion. We can either do that through imaging, but through whole heart imaging, including the atria, or we can use biomarkers like NT-proBNP. We need a widely available test, and it's in a UK context, that is much easier with a simple blood test that a family doctor can do. But we also need a bit of a conceptual framework to work with. So this is the normal physiology. You saw Jan eating a lot of salt in the previous presentation. With that, he will soon need to drink a lot of water to dilute that salt. So he will go into a state of water and salt retention. And if you ever weighed yourself before and the day after a high salt meal, you'll find that you weigh 2 to 3 kilograms heavier the following day. Your body responds to this by a rise in natriuretic peptides. So that's a healthy response, to get a rise in natriuretic peptides when you get water and salt retention. And you'll also get a rise in blood pressure. And that rise in blood pressure and the rise in BNP will increase water and salt excretion, and you'll get normalization of blood pressure and BNP. So the BNP is the body's natural defense against congestion. The problem with congestion is water and salt, and I would emphasize the water excretion. If you look at edema, it's a gallon of water or liters of water and a pinch of salt. So congestion is all about water retention with salt. And if there's a problem and you can't get rid of the water and salt, then that's what leads to congestion, and that will lead to a persistently elevated natriuretic peptide despite the water and salt retention, and you won't develop hypertension unless cardiac output, power output can be maintained. By that, so if there is a cardiac dysfunction, you won't be able to elevate the blood pressure in the way that's expected in order to excrete that salt and water load. And ultimately, that's what leads to heart failure. But potentially, we can engage at this point where you've got water and salt overload, you've got a rise in BNP, which is persistently elevated and is clearly not leading to excretion of salt and water. And it's useful just to go back to first principles of how we get from health to severe congestion. Remember that somebody who comes in with severe congestion is probably about 8 kilograms overweight. The vast majority of that will be extracellular and interstitial water. But you get there in a number of stages, and in fact, the plasma volume increases only slightly during the course of congestion. The weight gain is subliminal to begin with, and it's only as you progress that you see these the progressive weight gain. But the earliest signs of congestion are the dilatation of the left atrium and the rise in natriuretic peptides. And this will occur long before you see the weight gain, the lung interstitial fluid in the lung, the upper lobe venous diversion, the peripheral edema, the pulmonary edema, and the chest X-ray. We can potentially catch the problem much earlier in its course. And congestion, I agree with Professor Mullins, is at the core of all of this. If you have congestion, it leads to symptoms and signs. Congestion will provoke arrhythmias, predominantly atrial fibrillation, but also we know sudden cardiac death. Congestion is a leading cause of hospitalization. Congestion is a leading cause for death from heart failure. But also importantly, congestion will lead to cardiac remodeling. If you look at the changes in cardiac volume just with the use of diuretics, they're much larger than you will see with an ACE inhibitor, for instance. And if you control congestion with, yes, guideline recommended therapy, but also diuretics, then I think that you can favorably alter cardiac remodeling and therefore this vicious cycle that leads to death. So we've got good evidence. This is data from our clinic looking at improving the control of congestion. And if you get good control of congestion, you can greatly improve the patient's prognosis. And we use a panel which includes natriuretic peptides, but also a thing called the Jvd Ratios. So this is using the looking at the ultrasound of the jugular vein, the inferior vena cava, and also looking at lung B lines. And if you can keep the patient congestion-free, you dramatically improve the outcome of the patients. And this, yes, you can use guideline recommended therapy to achieve this, but these data were achieved before ARNIs, before SGLT2 inhibitors. These are achieved with diuretics, beta blockers, MRAs, etc. So is it important to pick up that early rise in natriuretic peptide? Well, this is a big study on diabetes where they measured NT-proBNP, and you can see that over the following 5 years, if you've got an elevated NT-proBNP, you're much more likely to get the clinical diagnosis of heart failure. but you're also much more likely to die. And of course, many of these patients, the diagnosis of heart failure will be missed. I don't know how good they are in Belgium or in Egypt, but I know that our primary care physicians miss the vast majority of heart failure. And indeed, the average duration between administering the first dose of furosemide and actually getting a diagnosis of heart failure is something like 3 years. So decongestive treatment is commonly administered years before the diagnosis of heart failure is made. So we need to look very carefully at this problem. We've done a similar study in the UK called the SECA study. This is combining natriuretic peptides and echo imaging. You can see that, well, first of all, many of these elderly patients, age 70, with long-standing type 2 diabetes, they all had type 2 diabetes for at least 5 years. You can see that the majority of these patients really didn't have an elevated natriuretic peptide. They had a good prognosis, the top 2 bars here. And if you look at echocardiographically at these patients, first of all, lots of them, we excluded anybody with a diagnosis of heart failure, anybody taking a loop diuretic. But nonetheless, the higher your natriuretic peptides, the more breathlessness you have, the more ankle swelling you have, also the more atrial fibrillation you have, and a dramatic increase in left atrial volume. So basically, these patients are in heart failure. They just don't have a diagnosis of heart failure. And we need to shift the diagnostic threshold down to this level, I think, if we're going to try and alter the outcome for these patients. And we're beginning to do that. This is a study just published in the European Heart Journal, the HOMAGE clinical trial. This is a trial which is inserting itself on the pathway of mineralocorticoid receptor antagonist clinical trials. We've, of course, got the RALS trial up here, an emphasis in patients with symptomatic heart failure. We've got the Pathway 2 trial here in patients with resistant hypertension, many of whom probably did have heart failure, but hypertension doctors, they often miss the diagnosis. So this was patients with basically structural heart disease. These were patients who had an elevated natriuretic peptide, but they didn't have heart failure. They didn't have severe left ventricular dysfunction. They weren't on a loop diuretic. They were in sinus rhythm. We treated them with a mineralocorticoid receptor antagonist. Striking benefits in terms of reduction in blood pressure, striking changes in the blood markers of fibrosis. So this looked like an anti-fibrotic intervention. Evidence of a reduction in atrial volumes and a reduction in atrial pressures and favorable cardiac remodeling. So all of the things that you would hope to do in a patient with heart failure, but before the onset of symptoms. So treating the patient for heart failure before the onset of symptoms. Just a brief mention that if you do have heart failure and you have normal natriuretic peptides, and even better if you have a relatively normal left atrial size, your prognosis is excellent. And we've shown this in very large studies. This was one called the Corona study looking at rosuvastatin some years ago. You can see the large number of patients recruited in this randomized controlled trial who had effectively pretty normal plasma concentrations of natriuretic peptides. That was actually, there were more patients with basically a normal natriuretic peptide enrolled in this study than in any other group. The average age of these patients was about 73. The annual cardiovascular mortality rate is down about 2%. that's the general population's annual cardiovascular mortality at the age of 73. So here are patients with a left ventricular ejection fraction less than 40% with heart failure who have a prognosis the same as the general population, age and sex matched. So it does make you think that perhaps the natriuretic peptides are the diagnosis of heart failure. And that's precisely what we're suggesting. Is just about to be published in the European Heart Journal, this first universal definition of heart failure. You have to think about the phenotypes of cardiac dysfunction. You have to think about the potential markers of congestion, which may be a raised natriuretic peptide or a dilated left atrium. There will be a few patients who have congestion due to renal dysfunction or other medical disorders who don't have heart failure. You'll have a lot of people with cardiac dysfunction who don't have congestion, but you'll have this group in the middle, heart failure. These are the patients with cardiac dysfunction and congestion. These patients will eventually develop symptoms and reduce functional capacity. They are the people who will have hospitalizations and mortality. But our role, of course, is to treat the problem at the source and not wait until that patient has got a 50% mortality at 1 year before we're willing to make the diagnosis, which I think is a dereliction of our duty as doctors. Thank you.
Thank you, Dr. Cleland. And actually, by the end of the presentation, still the universal definition of heart failure is a remote or far from being a fact. And I think from your presentation that the clinical part is very important, especially the symptomatology and the short of breath with exertion. In addition, of course, to the biomarker. However, I wanted to ask you about the, you know, after SGLT2 inhibitors and the recent the drugs for heart failure, we now want to start treatment early, even before the full-blown picture of heart failure. So how this implicate the definition of heart failure? Want to early detection of those who may develop heart failure in the future to start medications that may help them.
Yeah, I think that that's a very important point. And where I see this happening is if you've got a patient who's had a myocardial infarction, if you've got a patient with type 2 diabetes and hypertension, if you've got a patient, I would argue even in atrial fibrillation, although I think we might have to use a slightly different threshold for natriuretic peptides, that you should measure the natriuretic peptides in that patient. If the natriuretic peptides are fine, then I think you continue with your secondary prevention. You treat the hypertension, of course, you treat the hyperlipidemia. But I don't think that there is a strong argument then to introduce treatments that are the effective treatments for patients with heart failure. But for instance, if you had somebody with type 2 diabetes and hypertension, ischemic heart disease, and you find that the natriuretic peptides are elevated, then I think, yes, very much that patient is somebody who should be targeted with an SGLT2 inhibitor, even if they don't have symptoms of heart failure. I think a lot will depend, of course, on ongoing studies. There are studies of SGLT2 inhibitors in patients who have heart failure without left ventricular dysfunction. We hope that those studies might be positive. If they are positive, then of course that indicates that it's not the left ventricular ejection fraction that should drive the use of these agents, but rather the evidence of congestion. And the best evidence of congestion, the most sensitive measures that we have, are either to look at the left atrium or to look at the natriuretic peptides. And the simplest one in the clinic, which can be done even in family practice, is to measure the NT-proBNP.
Okay.
Yeah.
صبحي.
I have a question in every advisory board yesterday and 1 week before about the ejection fraction. Do you think still the standard of care is to divide the patient into numbers, ejection fraction, or you need tissue characterizations, or you are going to omit the mid-range and go into only reduced and preserved?
Okay, so a great question. I think the problem is when it comes to the diagnosis of heart failure that we have to remember we not only need to diagnose whether the patient has heart failure, but also what the cause is. And it does look as though the pathophysiology of people with heart failure and higher ejection fractions is different from people with heart failure and lower left ventricular ejection fraction. I think one of the major reasons for the HEF-MREF group is the diagnostic or the inaccuracy of echocardiography, that we know that left ventricular ejection fraction is only accurate to between 5 and 10%, and therefore inevitably there is a zone of uncertainty, a gray zone between these two pathophysiologies of HEF-REF and HEF-PEF. Some people like to call it HEF-NEF. We have also proposed last year that there are a group of patients who I think we all appreciate with a supranormal ejection fraction, these patients who have an ejection fraction of 80%, and they may be different from the ones who have an ejection fraction of 60%. So I think we need to keep an open mind. There is a continuous range of ejection fraction. I think that there will be different pathologies, underlying pathologies along that range of ejection fraction, with hypertrophic cardiomyopathy and amyloid perhaps sitting with the ejection fraction above 70-75%. These patients have a very poor prognosis, much worse than the prognosis of people with a normal ejection fraction, which we might call an ejection fraction between 60 and 75%. So I think we have a lot to learn still. I think the ejection fraction is part of the diagnostic workup. I don't think that you can diagnose heart failure on an ejection fraction. And if you want one single measurement from the echocardiogram, it is to look at the atria, and particularly left atrium if you're looking for left ventricular disease.
So we have symptoms, we have imaging, and we have the biomarkers. Regarding the biomarkers, which is considered now a cornerstone in the management of heart failure, but we have some problems with biomarker. We have some cases when the biomarker is increased, but the patient is not in heart failure, and we have vice versa. For obesity, for example, obese patients may have lower than normal biomarker, and this may add to the difficulty of the diagnosis. How this could implicate the definitions of heart failure regarding the issue of biomarkers?
Well, I think you make some good points, and in borderline cases, there's no doubt that extreme obesity can have a clinically significant impact on natriuretic peptides. Although I should point out that when we look at all of the studies on HEF-PEF, for instance, even in morbidly obese patients with a BMI above 40, the natriuretic peptides in patients who have otherwise a clinical diagnosis of heart failure are still grossly elevated. I think some of these patients, of course, have symptoms of heart failure because they're fat and not because they have cardiac dysfunction. So I think we do need to be careful. I think that's one reason why more people who are obese are diagnosed with heart failure is that if you had to carry 2 heavy suitcases, you would be breathless climbing stairs. And if you complain to your doctor, he might diagnose heart failure. So I think we need to be careful about interpreting symptoms in somebody who is grossly overweight. Having said that, I think, yes, you do need to think about adjusting the natriuretic peptides for the overweight patient, but the adjustments you need to make are quite subtle and modest. If the natriuretic peptide is grossly elevated, will usually be grossly elevated if there's serious cardiac dysfunction, even in a morbidly obese patient. We do know that patients who are fat and have symptoms and signs of heart failure with a normal natriuretic peptide have an excellent prognosis, suggesting that perhaps the diagnosis of cardiac dysfunction is wrong. It's part of the problem with natriuretic peptides is that it might be the gold standard. And when you compare the gold standard against inferior methods to assess the presence of heart failure, the gold standard will not look so good, but it's still the gold standard. I think that we're too much focused on symptoms. And as long as we focus on symptoms as key to the diagnosis of heart failure, we will get late diagnosis, we will get 50% mortality within 1 year of the first diagnosis of heart failure. I think there's a public health problem that we need to do something about. Remember, the prognosis of the patients who come to your clinics, you're only looking at the survivors, the people who have survived the onset of heart failure. And if you look at any survival curve for the first 6 months after the onset of heart failure, it's horrible. So we need to get earlier diagnosis if we're going to get a handle on this problem, and that will be natriuretic peptides. I guess the other one to think about is atrial fibrillation. There is a huge problem with atrial fibrillation of underdiagnosis of heart failure. I would say the majority of patients in atrial fibrillation are in heart failure, which is one reason why the natriuretic peptides are elevated. I do think that more research is required to determine exactly what natriuretic peptide cutoff we need for atrial fibrillation. I think it will be a little bit different from sinus rhythm, but it still alerts you to the fact that the patient has a serious cardiac problem that requires investigation and treatment.
Thank you very much, Dr. Cleland. This was really illuminating, and it gives a strong message to the attendees here in Egypt that we have to use the biomarkers. Thank you, and have a wonderful day. Thank you very much.
Thank you.